Assalamu alaikum everyone. Welcome to the neurosurgical case room after a pretty long hiatus. So, am I audible?
Walaikum salam. Yes, Dr. Kaval.
Okay, Dr. Sana, it's really joyful to hear you back. And okay, just give me a minute while I sort out a few things. Okay, so we are live already. Since the rapid clinical review series is already over, we are going to go back towards our 30 minutes timeline so that it's manageable for me with all the routine clinics and surgeries, etc. We are going to split clinoidal meningiomas in two sessions. The first session that we are going today is more on the relevant clinical anatomy, and maybe we will discuss some subtypes of clinoidal meningioma. But the radiology and the surgical procedures, the treatment that will be discussed in the session after this. But please remember, if you end up missing the anatomy, it will be really difficult to understand the clinical implication and the surgical procedure. So without further ado, let's begin. When I say the relevant anatomy, obviously the name is very self-explanatory. We are going to begin with the anterior clinoid process. And along with the anterior clinoid process, we will also take a look at the relevant structures, the structures surrounding it. So we know that ACP is a posterior projection of the lesser wing of the sphenoid. How do we know that? Obviously, we all know anatomy. And when you are rongering the lesser wing of a sphenoid during the surgery, when you are rongering it extradurally, if you continue going medially, you will end up reaching the ACP. Let me draw this. So those of you who have rongered sphenoid bone during the decompressive cranectomy for traumatic subdural hematoma, they would understand what I'm talking about. This is the lesser wing of the sphenoid, and this here is the anterior clinoidal process on this side. This is the other anterior clinoidal process, and then we have the opposite side, lesser sphenoid wing. So what ends up happening is we drill this portion away, change the color so that it's visible. We drill this portion away. Why? Because we want the floor of our bony craniotomy flush with the floor of the middle cranial fossa. So we rongeur this away. Once we rongeur this away, if we go medial enough, we are going to find anterior clinoidal process extradurally, and along with it some attachments. So I think the anatomy, at least some of it, would be pretty clear to those of you who have done this and during their own surgeries. When we talk about anatomy, I'm going to show you some pictures, but just have a clear idea. This is a triangular structure, right? This here, let me draw it again. This is a triangular structure. This portion is the plenum sphenoidal. This portion is the lesser wing of the sphenoid. And here we have the ACP. So what ends up happening is the medial base is obviously formed by the plenum sphenoidal. The lateral base is in continuation with the lesser wing of the sphenoid. What is important here? The inferior portion is important. Inferiorly, we have optic strut. And what is optic strut? It is a bridge of bone that connects ACP to the body of a sphenoid, but more importantly, it separates the optic canal from the superior orbital fissure. If the text went over your head, don't worry, we have a lot of images, but let me draw a very small optic canal somewhere here. Now, obviously, this is a rough illustration, but where the white dot is, this is the area of optic strut. Okay, so we have the ACP. Medially, we have plenum sphenoidal. Laterally, we have the continuation of lessening of the sphenoid. And inferiorly, we have the optic strut. Let's move on to some images so that it's clear. Okay, now this is a beautiful image. It's a dissection, and you can see the human bone and how it is slightly degenerating. Let me draw this again. In this region here we have the plenum sphenoidal. Okay, this here is the anterior clinoidal process, which if we track medially, then there is going to be the lesser sphenoid wing. Then we have this optic strut. What is it doing? This is the optic canal just under the anterior clinoidal process, and the optic strut is completing this canal, and it is separating it from the superior orbital fissure, which is right here. So anterior clinoidal process, slightly inferior we have optic strut. On the lateral side we have the superior orbital fissure. Medially and slightly inferiorly we have optic canal. Am I clear till here?
Yes.
Okay, let's move on to the next image. This is another cadaveric dissection. It's slightly blurred. I hope it's visible at your end, but this shows the plenum sphenoidal more clearly, and you would have a better idea about what I'm talking about. So this is an anterior clinoidal process. This is the left-sided anterior clinoidal process. You can see that there is plenum sphenoidal here, and if we had traced this towards the other side, there would be lesser wing of the sphenoid. Now, if you take a look, this here is the dorsum sella. So what this would be? What is this place?
Sella.
Yes, this is hypophyseal fossa or sella turcica, and around it we have carotid sulcus, because this place laterally, if can you notice the slope here? There's a slope here. This is not a flat bone, right? It is visible, right? The image is slightly blurred, but I could not find it in better quality. So on the lateral portion here, there is going to be carotid sulcus, which is more of it is for the cavernous sinus, obviously, but then it goes above. And in this region, we have the clinoidal segment of the ICA, which is pretty small, but it is important. So let me clear all of it. You can have some idea of these relations. We have other images as well. We have optic canal here. We have the superior orbital fissure here. ICA is slightly inferior, but then it comes up here, and then the post-clinoidal, the last segment of ICA, which is ophthalmic, and then we have the remind me the last segment of ICA, please. Does somebody else remember?
The terminal portion of
Ophthalmic,
ICU.
Yes, just before the terminal portion.
ophthalmic
Yeah.
and then communicating.
Yes, ophthalmic and then the communicating. So I was right, I was just mixing up the sequences. We have the clinoidal segment. After the clinoidal segment, we have the ophthalmic segment. After the ophthalmic, we have the communicating. So from the ophthalmic artery takes the origin. From the communicating, PCOM takes the origin. Let me clear all of it. Let's assume what is going to be on the sides. So here is in the middle, there's going to be pituitary, right? On the side, we are going to have cavernous sinuses somewhere here. Within the cavernous sinuses, there's going to be ICA, the cavernous segment. In the carotid sulcus, you can see that there's a sulcus here, and then it travels up just here, medial to the anterior clinoidal process, and this is the clinoidal segment. And this is extradural, but we are going to come to it later on. Am I clear till here?
Yes.
Okay, moving on. This is another zoomed in image. You can see all the structures that I've mentioned previously. There's the optic canal here. Right around the optic canal, you can now see the depression of the carotid sulcus, which is pretty visible. And this is the anterior clinoidal process. This region is the optic strut. So why is this important? This is important because when we have to do the anterior clinoidectomy, which is a really important part of the procedure for clinoidal meningioma resection, but it is also a staple in a lot of other procedures. For example, if you want to decompress the optic nerve, if you want to reach the ICA, you would have to take the anterior clinoid out. So if you end up taking the anterior clinoidal process out, optic strut is going to be the last segment of the bone that you would take. Once you take this, this can be completely fractured away. There is another technique in which some people prefer taking away the optic strut first so that the ACP can be fractured away without too much drilling, but that's for the surgical discussion. So we imagined the structures pretty much. I have some more images ahead. Optic nerve lies immediately medial. When it enters the optic canal, let's go back to the picture. This is ACP and this is the optic canal. It obviously looks medial. Then we have the ICA. ICA sits directly beneath the process. Let me go back. This here is where the ICA is going to be. So it's going to be medial and inferior both. Then we have the superior orbital fissure, which sits laterally, and it carries third, fourth, V1, and sixth nerve. Then superiorly, the ACP serves as an attachment point for the free margin of tentorium cerebelli. Unfortunately, I did not include an image for the tentorium cerebelli, but I'm sure you all remember there is attachment like this over here, and then there was an incisura, but there is an attachment on the anterior clinoidal process on the both sides. There are some other ligamentous attachments as well, but they are beyond the scope of discussion for today's session. So this is a slightly overwhelming image. What is the view? Can somebody comment on the view?
Sajida.
Yes, this is a sagittal cut and you're looking at it from the side. Why are we looking at it from the side? Because we want to visualize all the images that are related here. Because once you know the relevant anatomy, you would have a very clear idea of the clinical presentation and the structures that are going to come across during the surgery. Now, let's identify the anterior clinoidal process first. Please mute yourself. Who's this? Okay, so this is anterior clinoidal process here, the one that I outlined in the purple. Now you see that the ICA is curving. There's the cavernous segment of the ICA. This portion is the cavernous segment. And then just around the anterior clinoidal process, this portion is going to be the clinoidal segment. Clinoidal segment is marked by two rings. Can someone name those two rings for me? No one?
Dural ring.
Yes, there are
One
two
is a
First
dural.
form.
There are two dural rings. There's a proximal dural ring here, and then there is a distal dural ring here. The distal dural ring is a true ring. It, please mute yourself. I have no idea why I cannot see all of your participants, but please mute yourself and keep yourself muted. It creates a lot of disruption. This is the proximal dural ring. This is the distal dural ring. The proximal dural ring is sometimes complete, sometimes incomplete. There might be a middle clinoid process as well, which helps in completing the ring. But that's an anomaly. It's not the usual anatomy. But the distal dural ring is a complete dural ring, and onwards, this ICA is going to become intradural. Am I clear till here?
Yes.
Onwards the distal dural ring, the IC is going to be intradural. What do we imply from that? Before the distal dural ring, all of it is extradural, right? So this is within the cavernous sinus, this portion, and then this portion right around the anterior clinoidal process. This is purely extradural. Why does it matter? We are going to see that. Let me clear all of my slides. So what else can you see here? There are a lot of interesting structures going around. You can see the ICA curving around here, and you can also see optic nerve, which is, in this view, it's posterior to ICA. Is it visible? This here is the chiasm, and this is the optic nerve. Let me clear this. Then, what do we have here? This is the third nerve. Where is it going? It is going through the superior orbital fissure. And then this is the fourth nerve. This is the sixth nerve. So if this is a third, fourth, and sixth, then what is this small structure here in the purple?
Optic strut.
Optic tract, that's right. So now on the sagittal section, you can clearly see how optic strut is separating the optic canal from the superior orbital fissure and its inferior location to the anterior clinoidal process. What else do you see? You see the cavernous sinuses, you see the V2 here and V3 here within the cavernous sinuses, leaving the skull base outside. And if we see a petrosphenoidal ligament, there are a few other ligaments as well that attach to the anterior clinoidal process. And there is an interclinoid ligament as well, which attaches between the anterior clinoidal process and the posterior clinoidal process. So, if we assume that there is a lesion here, let me draw. Assume that there is a clinoidal meningioma here. What are the structures that it is going to involve once it grows big enough?
Carotid, optic
Carotid,
nerve,
yes, optic nerve,
maybe pituitary, or
pituitary,
the
yes,
cavernous sinus also.
cavernous sinus, all the nerves within the cavernous sinus, even the cavernous sinus ICA. Yes, sellar and suprasellar structures if it grows big enough. If it grows laterally, what is going to happen? What was on the lateral side? There was continuation of the lesser wing of the sphenoid bone, right? So if that portion ends up getting involved, there's a lobe sitting there, the temporal lobe. There is going to be compression on the temporal lobe as well. So the presentation of clinoidal meningiomas is going to depend heavily on the type of meningioma it is and the kind of structures it is involving. For example, let's draw this here. If we have a clinoidal meningioma on this side, it ends up hyperostosing the optic strut, and there is hyperostosis around the optic canal and the anterior clinoidal process. What is that going to do? It is going to cause direct compression over the optic nerve, and there might be you could see optic atrophy on the fundoscopy, and afterwards there can be involvement of the ICA. But since it is going to involve the optic nerve first, the vision is going to get deteriorated very quickly, and these lesions will get detected very early. In comparison, if the lesion is growing this side and somehow it is slightly away, it manages to stay away from the ICA, then it is going to compress all these structures posteriorly. And if we go inferior, then there's going to be sella here. This is not midline. If we say midline, then there's going to be sella here. So it can involve the sella as well. Am I clear till this point? I'm going to change the slide now.
Yes.
Okay.
Yes.
So where is this image from? Is it anterior or is it posterior to anterior clinoidal process? I want to see how good is your imagination. Let's
Anterior, I
go.
think.
Posterior.
No. Yes, it is posterior. Let's go back. I changed the slide on a purpose. Where's the anterior clinoidal process? It's here. Where's the pituitary? It's in the middle. Okay. So if there is a section somewhere taken around here, let me draw. This means that the section is slightly posterior to the anterior clinoidal process. You're not going to see the ACP, right? Now let's go back to that image. Are you clear now why this is slightly posterior?
Yes.
Because once we were talking about the anterior clinoidal process, we were talking about optic nerves. We were not talking about optic chiasm. You see optic chiasm here, and then the pituitary gland, then the infundibulum, and then the internal carotid arteries. So yes, it is the vicinity of the ACP, but it is slightly posterior. But these are all the structures which are going to get involved if a clinoidal meningioma manages to grow big enough. Right? So what are these structures? We have, I think, already discussed the cavernous sinus structures. We have ICA in the substance, and we have the sixth nerve in the substance as well. Rest of all the nerves, the third, the fourth, V1 and V2, they are in the lateral walls. So their involvement is going to come later on. But then again, it depends from which side the tumor is involving. Am I clear?
Yes.
Okay. Now, this is a very beautiful illustration of the clinoidal segment, the cavernous segment, and the anterior clinoidal process itself. Because it is also going to help you imagine what happens once you do a clinoidectomy. This is the proximal ring, right? This is the distal ring, which is a proper dural ring. Once the ICA goes in, it becomes intradural. There is no subarachnoid space here. There is no subarachnoid space, there is no CSF, etc., etc. If a tumor manages to grow here, it is going to attach on the adventitia of ICA directly, which is not exactly a good news. You can see the cavernous sinus ICA going below here, and that is also extradural. Now, what ends up happening is, once we do a clinoidectomy, what is our goal? Our goal is to protect the ICA because we know that ICA is in very close proximity, in fact, immediate proximity of the ACP. So what are we going to do? We are going to rongeur this from here, and we rongeur it till we leave only an eggshell-like bone over the ICA. And then we remove this bone manually and very gently. Because if you are going to close the burr, if you're going to take the burr very near this, then you do end up risking hurting the ICA. And what kind of burr is used for ACP drilling?
Diamond?
Yes, a diamond burr. Why a diamond burr? Why not something else?
Diamond is adramatic.
Yes, there is less chance of a diamond burr catching up on the dura. So there is lesser chance that you are drilling this portion and accidentally end up catching this dura in your burr, which is going to be a disaster for you and for the patient both. So always remember that this clinoidal segment is extradural, and once you're doing ACP drilling, it's in the immediate neighborhood. Am I clear till here?
Yes.
Then there is this middle clinoidal process. This is an anatomical variation. Sometimes when this is present, there is this proximal dural ring, which ends up making the clinoido-carotid foramen or carotico-clinoid foramen. I don't exactly remember the name. It's not of much consequence, but you should know that sometimes this is complete as well, if there is a middle clinoidal process. Let's move ahead. So to understand the clinical presentation, you would need to understand this image that I'm going to show you. For all the relevant structures, we have pretty much covered almost all of them, but a very quick review. Now you see, why did I say that that section was slightly posterior? See, we have the anterior clinoidal process here. I'm just going to draw red dots. These are the anterior clinoidal processes. This image is missing the ICA, but the ICAs are going to go like this. Okay. And these are the optic nerves here. This here is going to be optic chiasm. And we have the sella, the infundibulum, the dorsum sella, the cavernous sinuses, and the basilar plexus, which helps communicate both cavernous sinuses. And the lesser wing of the sphenoid on the both sides. This is the middle cranial fossa, and since it is the middle cranial fossa, it is going to host the temporal lobe. So, when there is going to be a lesion anywhere around here, it's self-explanatory by this point what structures are going to get involved. Optic nerve, ICA, cavernous sinus structures, pituitary infundibulum, if not the gland directly, temporal lobe if the lesion grows big enough, and if the bone is involved, then obviously hyperostosis of the medial portion of the sphenoid wing and hyperostosis of the optic canal. There can be hyperostosis of the orbital walls as well, and patient might present with proptosis. Am I clear?
Yes.
If the lesion grows big enough, it is going to cause compression over the temporal lobe. Patient might present with seizures as well, memory impairment, and if there is compression over the infundibulum, patient could present with DI. So the presentation is going to depend on the anatomical location of the lesion. Let me change the slide. So this is the step-by-step view of anterior clinoidectomy, and I wanted to show it today so that when we cover the surgical procedure in detail in the next session, I don't have to spend too much time on it. So what is the goal? The first thing, we unroof the optic canal if we want to decompress the optic nerve. If there is no decompression over the optic nerve, if there is no compression over the optic nerve, we don't need to unroof it, right? We can just take this anterior clinoidal portion here and drill it away. Once we drill it, there's going to be this strut, and we need to drill it away as well. Let's show you the next slide. So once we drill this strut away as well, and then the ACP, you can see that this portion is completely clear. And since this surgeon was also doing a de-roofing of optic canal, they also took the roof of the optic canal away as well. This particularly is important when we want extra access. Anterior clinoidectomy is not necessarily done in clinoidal meningiomas only. Once you, if there is an aneurysm of the clinoidal segment, if you want to reach that region, if you want to decompress the optic nerve, or sometimes even during other procedures, if you want extra space during a middle cranial fossa surgery, ACP can be drilled away. And along with ACP, there's a no-brainer that we are going to drill the medial sphenoid wing, lesser sphenoid wing, medial portion. Am I clear till here?
Yeah, optic strut is a part of which bone?
Optic strut would be a part of sphenoid bone.
Okay, thank you.
Yes, because it is connecting the anterior clinoidal process to the sphenoid bone body.
Okay.
So there is interclinoidal ligament. We have already discussed it. It connects the anterior clinoidal process to the posterior clinoidal process. Then we have carotid clinoid ligament. We discussed this in this image. A carotid clinoid ligament is going to be right here and make the carotid clinoid foramen. We move to the next slide again. Sometimes there is a complete osseous ring, which is keratoclinoid foramen. I mentioned that previously. Okay, for a surgeon, for us, what is most important on the pre-op CT? We need to see if anterior clinoidal process is pneumatized. Why is it so important? Even though the answer is written below in the last two lines of slides. Can someone take a bet? Why is it important for us to know if anterior clinoidal process is pneumatized preoperatively?
For CSF rhinorrhea.
Why for CSF rhinorrhea? What is going to happen if ACP is pneumatized? Okay, let's go back. So anterior clinoidal process is, if it is pneumatized, let me see if I have an image which would make this concept slightly easier. So this is anterior clinoidal process, and unfortunately this is a chiasma and I did not include that picture. What is going to be under the chiasma? Sphenoid sinus, right? There's going to be sphenoid sinus right here. Do you all remember the Sella the presentation, the pituitary presentation?
Yes.
There's going to be Sella here. And once there's, sorry, I keep saying Sella. I have no idea what I have against the sphenoid sinus. There's going to be sphenoid sinus here, right? So sphenoid sinus is connected to anterior clinoidal process if ACP is pneumatized. Is it clear, or do I need to go back?
Yes.
Clear.
Can you repeat again?
Yes, I think I keep making the same thing again and again. It's sphenoid sinus. Sphenoid sinus is going to be right under this. And here's the ACP. So this portion is going to be pneumatized. And anterior clinoidal process, if it ends up being pneumatized, then there will be a communication with sphenoid sinus, which is the nightmare for us as surgeons. Why? Because this increases the risk of CSF rhinorrhea, because it is now in direct communication with the sphenoid sinus and the ethmoid and the paranasal sinuses. It goes down, dripping the nose. Okay? If it is pneumatized, then it also changes our surgical approach. But let's move on for that. We are going to come back to this point later on in the presentation.
Yes.
Okay, let's go back to where we dropped off. This is the cisternal anatomy, and this is the inferior view. What do I mean by inferior view? We have taken the brain in our hands and we have flipped over it. The inferiormost portion is the superiormost, and the superiormost is under our own hands. Am I making sense here? You are looking at the brain flipped up, and there is no bone because you have picked up the brain and you're looking at it before it touches the bone. So there is no skull base here. All you see is the inferior view of the brain. Is that clear? Because it's really important. If you don't understand the orientation, you're not going to understand anything else.
Yes, clear.
So, what structures can you see here? This is the infundibulum, right? This is the infundibulum here. And what else is there? Around the infundibulum, we have the optic chiasm. This here is the ICA, the PCOM, ACA, which is going ahead, and connecting ACOMs. Please mute yourself. Okay, coming back. Why is it important? Because we need to know what cisterns are we working with. Let me clear all of this. So the cistern that you see on the sides, this is the right side, this is the left side. The cisterns that you see around the ICA, this is the terminal portion of the ICA. It's breaking in the MCA here, in the ACA, in the PCOM. So this is the carotid terminus. The cistern around here is the carotid cistern. And please remember the color, this is in purple for the purpose of this image. Whereas the cistern around here, which cistern is going to be this? This is going to be a chiasmal cistern, right? Since we have the optic chiasm here. So the chiasmal cistern and the carotid cistern, they are in close vicinity with the anterior clinoidal process. Am I clear till here?
Yes.
Yes.
All the structures are the same. The only thing that is different is you are seeing their arachnoidal coverings and the CSF filled within them. So now you're seeing the cisternal spaces. All the structures that we previously did, they are the same here, right? So we have the carotid cisterns on the side, which are wrapping, which is getting wrapped around the carotid terminus. And then we have the chiasmal cistern. Anteriorly, you can see the lamina terminalis cistern as well, but right now that is not our concern. Let's move ahead to the next image. If you understand this image, the classification is going to be really, really easy. This is the anterior clinoidal process. Let me draw here. This is the optic canal, and somewhere here there is going to be the optic strut. Okay, so if there is a lesion which is originating right around here under the anterior clinoidal process, then it is going to be type 1. If it is inferior to the anterior clinoidal process, where the clinoidal segment of ICA is, because we spent so much time on the anatomy, I'm sure you all would remember that clinoidal ICA is going to go around like this. You all remember that, right?
Yes.
Yes.
And you
Yes.
also remember that the clinoidal segment of ICA here was extradural. So if there is a lesion somewhere here, let me change the color. If there is a lesion here, then it is going to encase the ICA directly because there is no dura, no arachnoid in between. Any lesion that grows here is going to attach itself directly to the adventitia of ICA. Did that make sense?
Yes. Yes.
If you remember the picture that we saw before, ICA was extradural. I made it a point to mention this again and again. ICA is extradural here. So once there is a lesion in this region, then that lesion is going to attach directly to ICA and there is no intervening layer in between. What ends up happening is A, you see stenosis. B, the lesion is not going to be completely resectable. It will be a subtotal resection because obviously you cannot sacrifice ICA. That is type 1. Is that clear?
Yes.
Yes.
Where the type 1 is going to be, type 1 lesions are going to be slightly inferior to anterior clinoidal process, and where the extradural portion of ICA is, where the clinoidal segment of ICA is. So that is type 1. Then we have type 2, which is one of the most common presentations. Where is it going to be? It's going to be on the superolateral side. Now this is lateral. Remember, this was going into the sphenoid wing of the lesser wing of a sphenoid, and this was the lateral portion, the lateral base. So here, if there is a lesion, in fact, let's change the color. If there's a lesion here, it's going to grow slightly towards the lateral side, towards the temporal bone, towards the sphenoid wing, and maybe it will involve ICA, but there are going to be cisterns around here. What cisterns were here? On the lateral side of anterior clinoidal process and ICA, what cisterns were here? There was the carotid cistern, right? Yes, there was carotid cistern. Let me clear this. Change the color. There was carotid cistern in this portion, and immediately there was chiasmal cistern. Why is that important? Because those cisterns are going to make extra coverings around the lesion, and they are going to give us the plane during the surgery. So once there is type 2 has the arachnoidal layers of the carotid cistern. So it will not attach directly to ICA. Hence, a gross total resection is anatomically possible. Am I clear till here?
Yeah.
Type 3 is really interesting because type 3 is right at the origin of optic canal. So it's going to present early with the vision problems, etc., etc. And this is also going to be separated by chiasmal cistern. Now let me clear all of this and move to the types. Type 1 clinoidal meningiomas, we did that. It arises from subclinoidal dura at the proximal entry point where the ICA enters the intradural space. And since they are extraarachnoid, they can attach directly to ICA. This is just a repetition of what we have discussed throughout this session. Clinoidal segment of ICA is extradural. It lies between the proximal and the distal dural rings, and it is not surrounded by CSF, etc. So this is a clearer picture. And if I draw a lesion, the lesion is going to be here. Right before the ICA enters the dura, which is around the distal dural ring, this lesion is going to be here, and this portion is, we know, outside the dura. So the lesion is going to grow around the ICA and cause carotid stenosis. You're clear about type 1?
Yes.
Yes.
Okay. Let me move to the next slide. So surgical implications, they are pretty much understood. If there is a lack of arachnoid plane and there is direct adherence to the ICA adventitia, you cannot resect them completely. And there is going to be a higher rate of subtotal resection. There's also going to be a higher rate of recurrence as well. Where were type 2? Type 2 were superolateral, right? And since they were superolateral, they are going to be invested with the layers of carotid cistern. Now, we have already discussed that. Do I need to go over it again?
It's clear.
Okay. What is the surgical implication? It's really good. Since there are going to be arachnoidal layers, we can take the tumor off, and optic nerve is protected. Why? Because the tumor is going to grow towards the lesser wing of a sphenoid and towards the temporal lobe. So the optic nerve and the vision is going to stay okay. This is another illustration here, and you can see that we have the anterior clinoidal process. This is the type 2. Around the type 1, there's no dura, no arachnoid. On that, we are going to have the arachnoid of carotid cistern. Am I audible? Am I
Now
audible?
audible. Now audible.
Okay. So where did you lose me from? I have no idea why my internet is being problematic.
When you start this picture,
Okay.
Definitely.
Let me clear this again and go back. So this is ACP, and this is the type 2. This is type 1. This is type 3. Around type 2, we are going to have the carotid cistern. Around type 3, we might have chiasmatic cistern. Around type 1, we don't have any cisterns and any arachnoid, any dura, because it is outside the dura at present. Let's move to the next section. Now you can clearly see the lateral position of the carotid cistern here and the chiasmatic cistern here. So if there's a lesion growing somewhere here on the superior lateral side, then it's going to get wrapped into this arachnoidal layer. Moving on, we have the type 3 clinoidal meningiomas. They arise from the region of the optic foramen and it might extend into the optic canal. And there is direct involvement of the optic nerve, which leads to visual deficit. So it is diagnosed much earlier. How realistic is it to identify the subtypes on imaging? This was the first question while I was studying it for the first time. So somebody's saying my voice is still breaking. Is it breaking?
no, now it's clear.
Okay. So how realistic is it to identify the subtypes on these imaging? Not very realistic if the lesion is big, but if it is small to medium sized, you can. How we will see. And there are going to be some clues. How do you identify a CSF cleft or an arachnoid interface? You are going to see a CSF cleft around the lesion. If there is a CSF cleft visible between the tumor and the ICA, then it suggests a type 2. Whereas in type 1, you would see that the carotid artery is stenosed and there is no visible intervening fluid signal. In comparison, if there is hyperostosis or expansion at optic foramen, then that is a hallmark of type 3. Clear this? So this is a very small comparison table. If patient is presenting with early visual loss and the lesion is small, it is most likely going to be type 3, and you would need a CT with thin cuts to see whether there is optic canal extension there. Then if there is visible CSF cleft on T2 MRI, then that would mean that it could be type 2 and indicating an arachnoidal layer is present, which is good news for the surgeon. If ICA is encased and you see stenosis without any CSF cleft, most likely it is a type 1. Also, type 2 are more or less laterally positioned. They are the type which often gets confused with the medial sphenoid wing meningiomas. Am I clear till here?
Yes.
Yes.
Okay, so ultimately the classification is often confirmed intraoperatively. If it is getting dissected easily and you see a very clear arachnoid plane, then it is more or less likely going to be type 2. If you don't find an arachnoid plane, could mean that this was a type 1. So ACP pneumatization and how it impacts a surgical approach. If anterior clinoidal process is pneumatized, what is it going to do? It's going to create a direct route for CSF rhinorrhea and meningitis via sphenoid sinus. So if you see a pneumatized ACP on the preoperative CT, what are you going to do? You're going to go for intradural drilling in comparison with extradural drilling. Why? Can someone tell me why? No, because the intradural, when you're drilling it intradurally, it is, I'm audible, right?
Yes, audible.
Yes.
Okay, so once you're drilling intradurally, it's easier to pack the anterior clinoidal process with the fat or muscle or whatever you use to pack your nasal sinuses. So we can pack it, and then it also reduces the risk of postoperative CSF rhinorrhea. Once the rhinorrhea risk is reduced, then the meningitis risk is reduced as well. But what is the catch? The catch is that with intradural ACP drilling, you are going to get very limited exposure. The biggest reason to do an extradural anterior clinoidal process drilling is that there's significant exposure from that side. Also, there's another reason. Once you drill, what ends up happening? A, there's going to be bone dust. B, there's going to be heat produced because we are using drill and causing friction. Bone dust is a big problem if it is in copious amount, and if the anterior clinoidal process is hyperosposed. If you end up drilling too much and all that bone dust contacts the subarachnoid space, if the irrigation was not adequate, it is going to result in aseptic meningitis. What other possible complications can be? Vasospasm, right? There are a lot of important vessels around the region we were working in. ICA, there was ACOM, there was ACA, and there was PCOM. So if you are intradural and you are drilling, there is a risk of vasospasm. Then there is a risk of aseptic meningitis because this is irritant. The other risk is that all the heat that is being produced, it's going to affect the optic nerve, and it's a real concern. Hence, the intradural drilling is not the ideal approach when we are taking out the anterior clinoidal process. But if you don't have an option, go for it. If there's optic strut pneumatization as well, then the risk of entering sphenoid sinus is nearly 100%. And we have already discussed if there's hyperostosis, there's going to be more bone dust, there's going to be more heat. So if ACP is hyperostosed significantly, do not plan intradural drilling. Am I clear till here?
Yes.
So this still ended up being longer than our usual sessions, but I really wanted to cover all the clinoidal anatomy in the detail because now when we do the clinoidal meningiomas, the presentation, the radiology, the surgery, they are going to be really easy, inshallah. Are you all clear or there are any questions? Any questions?
Be the clinoidal part is extradural, right? Other part of ICA is intradural, right?
Say that again, please.
Only the clinoidal ICA is extradural.
Yes.
Okay.
ICA enters the segment that enters ICA. Sorry, I have no idea what I'm saying. Let me draw here. This is ICA, and we have this dura. Now there are segments, right? This portion here is the clinoidal segment. Before that was the cavernous segment. All of it is extradural. Once it enters the dura, which is at the distal dural ring, afterwards we have the ophthalmic segment and we have the communicating segment. Both of them are intradural. These are extradural. Is that clear?
Yes.
Okay. Thank you so much, everyone. This is a wrap for today. Tomorrow we have a different session with Dr. Mustafa Biskaya and on a different time. So we will probably continue the clinoidal meningiomas on Friday as a cover-up session since I could not manage to take on Monday or Tuesday either. Thank you so much, everyone. If you have any other questions or feedback, you can leave them on the WhatsApp group as always. Thank you. This is a wrap for
Thank you.
today.
Thank you.
Good night.